Professor Micev, who is pathologist in Belgrade University.
First of all, I would like to thank you, to organize the committee, to invite me on this lovely symposium. Well, the main role of pathology is to determine histologic pattern, to categorize malignant potential of the polyp, and these are definitions of main risk categories here according to ECSGAI guidelines. And of course, there is also incomplete removal, which is important for making a high-risk category of these polyps. And the main parameters are size larger than 10 millimeters, high-grade dysplasia, villous component, multiple adenomas, including so-called multiple flat adenoma syndrome, then serrated polyp larger than 10 millimeters and serrated polyp with dysplasia. And I will mainly focus on malignant polyp, which we just heard that it is defined as a cancer within a polyp invading through the muscular mucosa into the submucosa. And it's important to say that intramucosal carcinoma could not be considered as a malignant polyp. Well, the earliest invasive lesion, according to the literature, is with a diameter 3 millimeters, although I have never seen that. But the most are larger than 10 millimeters, and 50% of them are less than 20 millimeters in diameter. They comprise 2% of polyps and 10% of colorectal carcinoma, and overall it is estimated that malignant potential is 7 to 8%. However, if we compare malignant polyp, pedunculate, right, with the sessile, we shall see that in pediculated malignant potential is much lower than in non-pediculate, where it is nearly 15% measured by N1 stage. And some few words about intramucosal carcinoma. Despite that intramucosal carcinoma virtually has no metastatic potential, there are some situations where resection can be considered. For instance, if there is a true mucosal invasion, for instance, complete polypoid carcinoma, or single cell infiltration, or poor differentiation, and especially if it is on the sensitive background in patients with inflammatory bowel disease or hereditary syndromes, it must be considered. Well, something about handling. As a rule, a polyp should be received in one piece, and it depends, of course, on endoscopic technology. If it is piecemeal resection, then a piecemeal polypectomy cannot provide the essential information about the depth of the invasion and radicality. But in a specimen in a whole, there is an option for optimal fixation and orientation and preservation of the stalk, of course followed by measured, then margin argument and all tissues submitted. So the main point is identification and preservation of resection margins or the stalk. Well, for the smaller lesions, diminutive and small non-pediculated, some usual problems in everyday practice and some pitfalls are, for instance, searching for occult or missing polyps. In very small pieces, we can also miss the polyp. On initial sections, you cannot find a polyp, but after serial sectioning, you can find an adenoma emerging here from the top of this. And according to Sheikh, it is not so rare. In his series, it is up to 24% of the cases. And additional basal retraction, especially with the polypectomy, you can find that the histology seems worse near cauterized margin. And of course, margins in flat polyps are often poorly presented or even damaged. So you have to go to special technology like foam pad cassette processing or pinning. But anyhow, it's important to preserve margins and to make measurements. Well, as a rule, MRR or TMA specimen should be stretched and received pin corked and then fixed face down and margin inks. So pins, it's important to place loosely, not firmly, and not close to lesioner margins. And after that, parallel slicing going along pinholes. And it seems that perpendicular peripheral slices are more appropriate to see lateral margins. Well, there is a long list of poor prognostic parameters, and the first four are clinical more than pathological, including 3 centimeters diameter. But of course, the introduction of the deep submucosal invasion is important, especially after Haggett recognized the significance of the depth of the invasion as well as the carcinoma near or at the margin of a dissection. And as early as in 1966, Morrison had found the impact on histology, for instance, for lymphatic evasion, polypoid carcinoma histology, and poor differentiation. And very few things can be added from that time, such as tumor budding or stroma and etc. So, well, about resection margin, what is important that it can be somehow problematic because diathermy artifact can interfere. Well, we don't know, sometimes is it involved by adenoma or carcinoma, and in some cases we need serial sectioning to do it. And then it doesn't matter if it is direct involvement or it is up to the distance of 1 millimeter. Relapse rate is almost the same. It is about 21 to 35%. And it is surprisingly low metastatic potential, but only under one condition, if there is no other high-risk histologic parameters. Well, that submucosal invasion in pediculated polyp is also important. Well, Haggett classification of the depth of the invasion tells about the invasion to the head or to the neck, and it is level 2 or level 3, any part of the stalk, and the level 4, it is so-called submucosa propria. Well, it is beyond the stalk and above the muscularis propria, and he found it is important. But now, nowadays we know that it is very low risk for malignant progression if the stalk invasion is 3 millimeter or less. And similarly, Kikuchi found that the greatest malignant potential is with deep submucosal invasion, SM3 level. Today we know that superficial submucosal invasion less than 1 millimeter is of low risk for malignant progression, and we can compare it with the depth greater than 2 millimeters and the width 4 millimeters at the invasion front, which bears 20% of risk for further progression. Something about unfavorable histologic features. These are tumor grade, then tumor border configuration, of course lymphovascular and perineural invasion, and tumor budding. And any of these bears 20% of risk for malignant potential. And something about poor differentiation, it doesn't mean only high-grade histology, but some special histologic types like signet-ring self, micropapillary, or mucinous, so-called coloid carcinoma. Well, just a few words about malignant serrated polyps. They are quite rare, especially in the rectum. And there was a recent study by Murakami who came with these results that SSA or P with submucosal invasion compared to conventional adenoma exhibit a higher potential for lymphatic invasion and for lymph node metastasis. And they have distinct histopathological features like mucinous components, serrated architecture, tumor infiltrating lymphocytes, Crohn-like inflammatory reaction, and absence of desmoplastic reaction. And Of course, not surprisingly, there is more frequently loss of MLH expression, which means that it means that this microsatellite instability profile. Well, some usually problems about the histology is that confusion of nomenclature is still there, and pathology report often is not clear, at least in my country. Then line of resection is not identified always, and pseudocarcinomas invasion is misinterpreted. And there are some terms to be avoided, for instance, superficial or microinvasive focal, early carcinomas, those transformation. And to overcome the problems with reporting, structured protocol reporting and using a pro forma is strongly recommended. Well, if we compare these two villus adenomas, at first glance we suspect invasion here. But does it early carcinoma? No. On the left polyp we have invasion, and on the right we have pseudo-invasion. And it's because we have on the left side infiltrated growth, disruption of stromal elements, and desmoplastic reaction. And on the other side, in pseudo-invasion, you have a lack of infiltrating pattern, lack of tumor dysplasia, presence of lamina propria around this mispositioned glands, and presence of hemorrhage and hemosiderin. It's the farmost in the sigmoid colon. And it can be quite tricky on biopsies, because in superficial biopsy it is very often misunderstood as a false invasion. And also there is some phenomenon of lymphoglandular complex with inverted adenomatous growth giving rise a suspicion of carcinoma. And at summary, I'll say that we have make pathology report clear. Then for adenoma, we have a report high-grade dysplasia and villus component, and of course with a suspicion of cancer or with diagnosed cancer, we have to report marginal status, then grade and angiolymphatic invasion, and with T1 cancer, we should add budding and deep submucosal invasion if there is. Well, at the end, greetings from Belgrade, from the place where there is a monument of Rigas Ferraus, and this is his last word. Thank you for the attention.
Thank you for your talk. As we are very late, maybe one question from the floor? No? So thank you very much. And we will